Imagine, right, that you walk into a doctor's office because your knee keeps buckling.
Mm-hmm.
Like, you explain to them that it feels completely unstable. You can't run, you can't jump without it just giving way.
Right, a structural issue.
Exactly. And the doctor, looks at you, takes a quick look at an x-ray and says, well, your bones haven't completely snapped in half. So that instability you're feeling,
Yeah.
that's just subjective.
Oh, you would be absolutely furious. I mean, anybody would.
You'd probably find a new doctor immediately.
Yeah.
But here's the wild thing. For decades, that is remarkably close to how the medical establishment has treated women who report a sudden loss of structural support in their pelvic floor.
Yeah.
Specifically, a condition that is often referred to as vaginal laxity.
It is. And, the frustration there really stems from just a fundamental misunderstanding of biomechanics.
Right.
For a very long time, clinical medicine has sort of treated this highly complex, weight-bearing muscular suspension system as if it were just, I don't know, a static empty tube.
Which makes no sense. So today, we're taking a much closer look at the actual architecture of that suspension system.
Yes.
We're doing a deep dive into a really fascinating stack of clinical data. We've got sources ranging from the Cleveland Clinic and the Royal College of Obstetricians and Gynecologists to some really detailed functional anatomy research.
And even some safety warnings from global health regulators, which we will definitely get into.
Oh, yeah, we are definitely getting into that.
Yeah.
But our mission today, the core of this deep dive, is to answer a highly specific question for you. Can weakness in the perineal body actually affect vaginal tightness?
And to answer that fairly, we really have to move past the aggressive cosmetic marketing and, frankly, the embarrassment that usually completely clouds this topic.
Yeah, totally.
The sources we are looking at today are great because they strip away all that noise to just reveal the pure mechanical engineering of the human pelvis. It's fascinating.
It really is. So I want to start by just mapping out this territory because I think, most people have a vague idea of the pelvic floor, but very few of us actually understand the specific anchor points. So if we're going to talk about structural support, we have to talk about the perineum.
Right. So the perineum is basically the real estate at the very base of your pelvic cavity.
Okay.
If you map it out anatomically, it's a diamond-shaped region.
A diamond. Got it.
Yeah. And if you draw a horizontal line right across the middle of that diamond, connecting your sits bones.
Wait, really quick, for the listeners, the sits bones are those bony prominences you feel when you sit on a hard chair, right?
Exactly, yes.
Okay.
Those hard bones. So that line divides the diamond into two triangles. You have the urogenital triangle in the front, which houses the urethra and the vagina, and then the anal triangle in the back.
Okay, so a front triangle and a back triangle. And right in the middle of that diamond, right at the intersection of those two triangles, is the perineal body.
Yes. And that specific structure is just an absolute marvel of biological engineering.
Wow.
In females, the perineal body is only about 1 inch to 1.5 inches long.
Wait, that's it? 1.5 inches?
That's it. It's this dense, tough, fibromuscular mass. I mean, it doesn't look particularly imposing on an anatomical diagram or anything.
Yeah.
But it serves as the central anchor point where multiple crucial pelvic floor muscles intersect, weave together, and attach.
Okay, I want to make sure we really understand what these muscles actually do because we hear a lot of Latin names thrown around, but how do they function?
Yeah, let's break it down. We can look at two major players here. First, the bulbus spongiosus muscle.
Bulbus spongiosus.
I try saying that 3 times fast, right? These run on either side of the vaginal opening, and their main job is to provide that natural resting tone.
Like a hug.
Exactly, the resting hug around the lower third of the vaginal canal. Then you have the transverse perineal muscles.
Okay.
These run horizontally across the pelvis, stabilizing that central point from side to side. And both of these muscle groups, along with parts of the levator ani and the external anal sphincter, all converge and anchor directly into that little perineal body.
So if we think about the pelvic floor as almost like a complex suspension bridge or maybe a massive woven hammock.
A hammock is a great visual, yeah.
A hammock that has to constantly support the weight of your bladder, your uterus, your bowel.
Yeah.
The perineal body is essentially the central structural knot that holds all those primary load-bearing ropes together.
Yes. Clinically, we actually describe that specific function as providing level 3 support.
Okay.
It literally tethers the distal part of the vaginal canal, meaning the area closest to the outside opening, to the bony ring of the pelvis.
Which honestly perfectly answers the core question of this deep dive.
It does.
If that central knot gets untied or frayed or damaged in any way, The tension of the entire hammock just vanishes.
Exactly.
So weakness in the perineal body absolutely affects vaginal tightness because the muscles providing that resting hug lose their anchor point.
The physics of it are just undeniable. Because it anchors the muscles surrounding the vaginal opening, the introitus,
Yeah.
any structural compromise to the specific mass immediately ruins the tension of the vaginal walls. Without that base of support, the walls of the lower vagina can actually begin to avert or essentially sag outward, which completely alters the mechanical friction and support.
See, I'm kind of stuck on this idea of feeling loose, though.
Okay.
Like, if the foundation drops and the hammock sags, shouldn't we be able to physically see the internal organs dropping?
You would think so.
Yeah, isn't a feeling of laxity and a physical prolapse just the exact same thing?
That assumption right there is precisely why so many people receive the wrong treatment.
Really?
Yeah, they are two entirely different phenomena, even though they share the same neighborhood and, they do often overlap.
Okay, explain that.
Well, pelvic organ prolapse, or POP, is a structural anatomical descent. It means an organ like the bladder, the uterus, the rectum has visibly and physically dropped down into the vaginal canal.
And that is something a doctor can definitively measure, like with a ruler.
Very precisely. The standard clinical tool for that is the POPQ
Yeah,
system. Yeah, it stands for pelvic organ prolapse quantification. A physician uses a grid to measure exactly how many centimeters a specific organ has descended relative to the hymen.
So it's hard, undeniable, objective data.
Exactly. But laxity, on the other hand, is defined in the medical literature as a purely subjective sensation.
Subjective.
Yes. It is the individual's feeling of looseness. It's a reported decrease in friction or a feeling of gaping.
So you could have a documented prolapse where an organ has physically dropped on a chart, but not actually feel any sensation of looseness yourself?
Yes, absolutely. Or, the exact reverse, which is incredibly common.
Wait, really?
Oh, yeah. A patient can feel profound, distressing laxity with absolutely zero measurable organ prolapse on a PUOPQ chart.
Wow.
One of the most common physical manifestations of this sensation is something called air entrapment. Sometimes it's referred to clinically as vaginal wind.
Vaginal wind, okay.
Yeah. Because the resting closure pressure of the lower vagina is compromised, air enters the canal during normal movement, or like doing yoga, exercising, and then it is audibly expelled.
Which has to be so distressing.
It is highly distressing, but here's the kicker. It won't show up as a prolapsed bladder on a doctor's grid.
I mean, the real-world impact of misunderstanding this distinction is huge. Because misdiagnosing a sensation of laxity as a structural organ prolapse leads to completely the wrong intervention for the patient.
Oh, 100%.
Like if you feel a loss of tension because your central perineal muscle is torn, undergoing a major surgery to lift and suspend your bladder isn't going to restore that tension at all.
Right. You would literally be addressing the symptom in the wrong room of the house.
That is a perfect way to put it, which is why identifying the specific culprits that damage that central anchor is so vital. We have to look at what actually breaks the perineal body.
Yes, let's talk about the culprits.
The most obvious trauma here, and the one that takes up a massive portion of the clinical data we looked at, is childbirth.
Naturally.
Pushing a human out of that space is an immense mechanical strain.
It is. And the statistics are pretty sobering. Approximately 85% of people who give birth vaginally will experience some form of perineal tear.
85%.
Yeah.
That is an overwhelming majority.
It really is.
But I imagine, not all those tears permanently destroy the structural knot, right?
No. Many are first or second degree tears that heal relatively well, involving the skin or just the superficial mucosa.
Okay, that's good.
But a significant clinical challenge arises with OASIS.
Oasis, what is that?
Obstetric anal sphincter injuries.
Ouch. That sounds severe.
It is. These are third and fourth degree tears. A third-degree tear violently rips right through the perineal body and straight into the anal sphincter muscle.
Oh my gosh.
And a fourth-degree tear goes even deeper, tearing completely through the muscles and into the lining of the bowel.
Wow. And, reading through the sources, the damage isn't just about the initial tear itself, is it?
No.
It's about how the body attempts to repair it. Because even if a doctor performs a textbook repair, or they performed an episiotomy, which is a surgical cut to intentionally widen the opening, the resulting scar tissue fundamentally changes the biomechanics.
You hit the nail on the head. Scar tissue is fibrotic. It does not behave like healthy, elastic, contractile muscle. When a severe tear or an episiotomy heals, That thick scar tissue can cause asymmetrical pulling.
Asymmetrical pulling.
Right, because it heals incredibly tight in one specific direction.
So it's essentially pulling the central knot off-center.
Exactly. It completely distorts the tension. It pulls the vaginal opening tightly in a way that paradoxically forces the opposite side to gape.
Oh, wow.
Right. So it mimics a loose feeling on one side while simultaneously causing severe pain or tightness right at the actual site of the scar.
That sounds incredibly complicated to deal with. So, okay, a physical tear breaks the muscles. But what if the muscles are perfectly intact, yet someone still feels a sudden, profound loss of support and friction later in life? That points to a change in the tissue itself.
It does. And that points directly to genitourinary syndrome of menopause, or GSM.
GSM.
Yeah. When a person enters menopause, their systemic estrogen levels drop dramatically. And we often think of estrogen in terms of, hot flashes or bone density.
Right, that's the classic association.
But the vaginal tissue is actually incredibly rich in estrogen receptors. Estrogen is the primary driver that stimulates blood flow and collagen production in the vaginal mucosa.
So it maintains the structural integrity of the lining.
Exactly. Without a steady supply of estrogen, the tissue undergoes severe atrophy. It physically thins out.
Okay.
A healthy vaginal lining has rugae, these natural accordion-like folds that provide elasticity and friction.
I see.
As estrogen plummets, those folds just flatten out. The tissue becomes fragile, extremely dry, and just loses its natural elasticity.
In this scenario, the perineal body hasn't been torn at all.
Not at all.
The suspension cables are completely intact, but the lining of the canal itself has completely changed its texture and thickness. It loses its natural grip, which results in a sensation of laxity that probably feels almost identical to muscle weakness, but stems from a completely different physiological root.
Exactly. It is a mucosal change, not a muscular defect.
Okay, so I get childbirth as a cause, obviously, and I get menopause. But if laxity is fundamentally about stretching the foundation, surely anything that creates constant repetitive downward pressure over years would do the exact same thing to that central knot.
The clinical data completely supports that logic.
Yeah.
Anything that chronically increases intra-abdominal pressure will wear down the pelvic floor over time. Chronic coughing is a major one.
Interesting, like from smoking.
A persistent smoker's cough or severe chronic asthma acts like a constant rhythmic hammer striking that suspension bridge.
Wow.
Chronic constipation and the associated straining does the exact same thing.
That makes total sense.
Even occupational hazards, like repetitive heavy lifting without properly engaging the core, that forces all that intra-abdominal pressure straight down onto the perineal body.
Our sources also point out a genetic vulnerability here, which I found fascinating. Some people are just built with a more flexible foundation.
Yes, connective tissue disorders play a really fascinating role here. Conditions like Ehlers-Danlos syndrome directly affect the body's ability to synthesize strong, rigid collagen.
Oh, right.
For these individuals, the ligaments and fascial tissues of the pelvic floor are inherently more hypermobile. They're prone to stretching out.
So they don't even need a specific trauma.
Exactly. They can experience severe, debilitating laxity without ever experiencing childbirth or menopause, simply because their biological building blocks are just too elastic to hold the tension.
Okay, so we have mapped out a whole landscape of causes here. The central knot could be physically torn from childbirth. It could be asymmetrical from scar tissue. It could be thinned out from a lack of estrogen or stretched from chronic pressure or genetics.
This is a wide range.
Because the underlying causes are so wildly different, the way you fix the loose feeling has to be specifically targeted. You can't just apply a one-size-fits-all solution, right?
No, definitely not. Treatment always begins conservatively, and it has to match the mechanism of the injury.
Makes sense.
If the issue is pure muscle weakness, perhaps the muscles are intact, but they're just overstretched after a standard delivery, the clinical gold standard is pelvic floor muscle training, or PFMT.
Which our sources are very, very clear about. This is not just, squeezing a few kegels while you're stopped at a traffic light.
Not at all. I mean, the guidelines recommend a dedicated, intensive program guided by a specialized pelvic health physiotherapist, usually lasting anywhere from 6 to 16 weeks.
That's a real commitment.
It is. The goal is to neurologically reconnect with those transverse perineal and bulbospongiosis muscles and physically rebuild their tone, their endurance, and that resting closure pressure.
But wait, if the culprit is that genitourinary syndrome of menopause we talked about, where the tissue itself is just thin, dry, and flattened out doing thousands of perfect kegels, isn't going to fix a cellular lack of estrogen, is it?
Right. Muscle training won't solve a mucosal problem.
Yeah.
For GSM, the first-line treatment is localized vaginal estrogen.
Localized.
Yes. This is delivered via creams, small dissolving tablets, or flexible rings directly to the vaginal tissue. Because it's localized, it stays right there in the tissue without significantly raising estrogen levels in the rest of your bloodstream.
Well, that's a crucial distinction.
It is, and it effectively reverse engineers the atrophy. It restores the blood flow, thickens the mucosa, and brings back those natural folds and hydration.
Wow.
It doesn't tighten the underlying muscle, but it restores the tissue's function so effectively that the subjective feeling of laxity often just resolves.
All right, so this brings us to a highly controversial part of our sources.
Yes, I knew we'd get here.
If you scroll social media for like 30 seconds, you will inevitably see targeted ads for vaginal rejuvenation energy devices.
Oh, they're everywhere.
They're marketed as a total magic wand, right? Promising to tighten everything up during a lunch break, no surgery, no physical therapy required. How are these devices actually working on the tissue?
Well, the clinical data surrounding energy devices is deeply polarizing. The market is dominated by two primary technologies.
Okay, what's the first one?
First, you have radiofrequency devices, like Votiva. These use temperature monitor heat to penetrate the deeper submucosal layers, theoretically creating a mild thermal injury that stimulates the body to rush in and remodel the collagen.
All right. And the second type?
Traditional CO2 lasers, and these are ablative. They actually vaporize microscopic columns of the vaginal mucosa to force a rapid, intense healing response.
Okay, but aesthetic clinics publish reports all the time saying these improve moisture and maybe mild incontinence. But the broader global medical community is throwing up massive red flags. Why the discrepancy there?
It really comes down to a fundamental misunderstanding of tissue biology. I mean, a CO2 laser might be highly effective for tightening the thick, dry epidermis of facial skin
Right.
because that's constantly exposed to air and has a rapid cellular turnover. But the vaginal mucosa is an internal, delicate, mucus-producing environment that relies heavily on a complex network of underlying blood vessels.
Which means treating the inside of the pelvis like the skin on your face carries huge risks.
Huge.
I mean, the FDA in the United States has issued severe warnings against using energy-based devices for vaginal rejuvenation, specifically citing reports of severe burns, permanent scarring, and chronic pain.
Yeah, and they aren't the only ones. The National Institute for Health and Care Excellence in the UK NICE classifies transvaginal lasers for these conditions as investigational, concluding there just isn't enough robust evidence to prove they are safe for routine clinical use.
And didn't Australia do something even stricter?
Yes, the therapeutic goods regulator in Australia took it a step further. They recently canceled all approvals for these devices entirely.
Wow. And the case studies in the data explain why, honestly.
Hmm.
Vaporizing that delicate mucosal tissue can lead to strictures.
Yes. Strictures are these thick, inflexible bands of fibrotic scar tissue that form mid-vagina as the burns attempt to heal. Once those strictures form, they eliminate whatever natural elasticity was left, making intimacy impossibly painful.
So basically, using a skin-tightening laser to fix a torn perineal muscle is like trying to fix a snapped suspension bridge cable by painting the road a different color.
That is a brilliant analogy, yes.
Like, it might create a different texture on the very surface for a few months, but it does absolutely nothing to restore the mechanical tension of the bridge itself.
Precisely. If the perineal body is physically torn, if those bulbospongiosis and transverse perineal muscles have violently separated and healed with a massive gaping space between them, no amount of localized estrogen, physical therapy, or thermal laser heat is going to magically pull those detached muscles back across the gap.
Which naturally leads us to the definitive structural repair.
Yes. When there's a true anatomical defect in the perineal body causing severe dysfunction, the ultimate fix is a functional reconstructive surgery called a perineorrhaphy.
Okay, so what does that procedure actually entail? Like, how do they physically fix the knot?
Well, a surgeon carefully dissects the perineal area to locate the retracted, scarred ends of those separated muscles. They meticulously remove the dysfunctional asymmetrical scar tissue left over from the initial tear or the episiotomy.
Okay.
Then they physically suture the transverse perineal and bulbospongiosis muscles back together at the midline, intentionally reestablishing that central anchoring knot.
Wow.
Yeah, they are rebuilding the literal foundation of the pelvic floor to restore that critical level 3 support and close the gaping introitus.
And the clinical guidelines are quick to differentiate this from purely cosmetic procedures, which is important.
Very important.
This isn't a designer surgery meant to change the aesthetic appearance of the anatomy. It is a functional reconstruction. It's about restoring the biomechanical integrity of the pelvis so a person can, jump, sneeze, and just exist in their body without feeling like their structural support system has totally collapsed.
Exactly. The entire goal is returning the patient to an active, pain-free baseline.
We have covered a tremendous amount of ground today.
We really have.
We start with a very specific anatomical question. Does perineal body weakness affect vaginal tightness? And the sources gave us a definitive yes. The perineal body is the central anchor point. When it weakens, the tension of the entire pelvic hammock is compromised.
But we also learned that the symptom of laxity is incredibly nuanced, right? It could be a profound muscle tear from childbirth. It could be the asymmetrical pulling of episiotomy scar tissue.
Right.
It could be the microscopic thinning of the mucosa due to an estrogen drop in menopause, or even the slow, steady stretching from a chronic cough.
And because the physiological roots are so wildly different, the treatments have to be precisely matched to the actual problem. Pelvic floor physio rebuilds the muscle tone. Localized estrogen restores the tissue thickness. And surgical perineography repairs the torn structural cables. Understanding the absolute difference between a subjective feeling of laxity and a structural, measurable pelvic organ prolapse is honestly your best defense.
Yes.
It prevents you from falling for aggressive cosmetic marketing or undergoing unnecessary procedures that just don't address your specific anatomical reality.
It equips you with the vocabulary to walk into a clinic and actually advocate for yourself, to ask for a proper functional assessment of your pelvic floor muscles, rather than just accepting a generic diagnosis.
This deep dive has fundamentally shifted how I look at pelvic anatomy. It's an area of human biomechanics that is so rarely discussed with the scientific rigor it deserves, yet it serves as the literal foundation for our daily comfort and mobility.
It's true. And as we wrap up, I just keep coming back to a glaring contradiction in the medical literature, and it's something I really want to leave you to think about.
Okay, what is it?
Well, we discussed how physicians use the POPQ grid to perfectly objectively measure the physical drop of a prolapsed bladder in centimeters.
Right, it yields undeniable numerical data on a chart.
It's hard science, but as we also established, there is no objective medical test, no ruler, no grid, no lab draw to measure the purely subjective symptom of vaginal laxity. It relies entirely on the patient verbally reporting a loss of sensation or a feeling of gaping.
Yeah.
So in a medical establishment that notoriously demands measurable, objective data to validate a condition, we have to ask, how many people's very real, very distressing symptoms of structural pelvic instability have been dismissed or ignored for decades, simply because their physical reality can't be plotted neatly on a doctor's chart?
Wow. That is a really profound perspective. Just because the medical field hasn't invented the ruler yet doesn't mean the foundation isn't cracked. Thanks for taking this deep dive with us.